Hi everyone, today I would like to discuss something that's starting to become very apparent. It's called the deaths of despair, increasing suicide deaths in connection to low levels of educational attainment. You might be wondering, why exactly is there a cause for concern? Well, the purpose of my work here is to express how increases in suicides have contributed to an increasing overall mortality rate, particularly amongst those with a high school degree or less. And this is based on some research that's been done by CAUSAL and Deaton. I definitely suggest reading that. It's the cornerstone of this paper, and it's definitely brought a lot of attention to suicide in the past few years. Now, what exactly is the underlying problem here? Well, by 2014, there was a large increase in midlife suicide mortality that came to be coined as the deaths of despair, since suicide was actually offsetting the mortality gains made amongst children and the elderly living longer. Now, you might be wondering, what exactly is the outcome versus the exposure? Well, in this presentation, the exposure is the level of educational attainment, and the outcome is the mortality rates due to suicide. The problem here is that due to the increasing mortality rates, once again, as I stated before, there is a deterioration in overall life expectancy at birth in the US between 2014 to 2015. Even now, the death rates are compounding upon one another, particularly amongst the poor and the minimally educated. The three studies I used were chosen meticulously and intentionally. Study 1 is in the Middle East. It focuses on suicide in the Hamadan province of Iran. Study 2 looks at emergency departments in the United States. And Study 3 focuses on suicides and attempted suicides in Australia. I do give a little bit more background that's in depth for Study 1 through 3. But I will essentially get to the more important information when I get into Henneken's criteria. And I recommend reading this if you have any spare time. So Henneken's criteria, as we're probably all very familiar with by now, involves 8 components. They are chance, bias, confounding, strength of association, biologic plausibility, consistency, temporality, and dose response. And in other words, if you can meet these criteria, then you might be able to posit having a causal relationship. So this is a framework for interpreting in case anyone might be unsure of what these criteria represent. So this cleans it up and describes it very well. But the two main questions here are, 1, is there a valid statistical association? And 2, can this valid statistical association be judged as cause or effect or not? That's what we're going to find out today. Now I'm going to start with chance. So in other words, is the association likely to be due to chance? The answer to that is no in these cases. For Study 1, Study 2, you'll see that the p-values are 0.001 and 0.002, which are far less than the 0.05 that we're so accustomed to. And when it comes to Study 3, the population attributable risk, was very high, and I'll be able to give you more details about that in future slides. Now, what about bias? Is that something that we can ever truly escape? I don't think so. Bias is inextricably intertwined in any studies, no matter how hard you might try to get rid of it. So in study 1, there might have been a little bit of measurement bias, such as possible underreporting of suicide due to some stigma, especially in Iran, drug abuse overdoses that were occasionally classified as suicides when they weren't. And we will see about the rest. In study 2, there was a chance of recall bias being a problem. All the subsequent information is subject to the recollection of the study participants, and this is where memory failure can occur, especially the further away from the event you go. So, as you can see, the data collection included a baseline interview, 2 chart reviews, and 5 telephone surveys. Now in study 3, we had a selection bias, we had a slight measurement bias, and once again, given the self-reported nature of the survey, measurement bias may also be present in estimates. Not only that, but due to all of the surveys and the questionnaires given, there's certainly a chance for more recall bias due to giving out more surveys. Now, what about confounding? Well, the first study did an excellent job of controlling for what we generally would consider to be important, those being gender, marital status, education, occupation, and residence. Year of suicide was stratified along with age. Now, for study 2, it was quite similar. The same things were controlled, except there were a couple additional ones like ethnicity, sexual orientation, marital status, habitation, family deaths, and interestingly enough, involvement in the armed services. And for study 3, only gender was controlled. However, out of all 3 studies, I wish that access to health insurance had been studied, since this is of critical importance. Now we get to a very important component, strength of association. Now for study 1, I found adjusted odds ratios embedded in the paper, and this turned out to be a moderate relationship. However, the odds ratio of completed suicide is increasing 1.43-fold per 10 years of age, which is very troubling in that it indicates it could get worse over time. Now in study 2, given the odds ratio we had and the p-value, we once again had a moderate odds ratio. In study 3, the population attributable risk was used, and this was a moderate relationship in that 1/3 of suicide attempts are attributable to low educational status. For biologic plausibility, what I want to know is it possible for a causal association? And is it consistent with existing biological and medical knowledge? In all 3 studies, the answer to this was yes. Now, what about consistency? In other words, between and amongst the studies conducted, is there a sense of consistency in the findings? Once again, that was a resounding yes. Temporality. Is the time sequence compatible? In other words, does the exposure occur prior to the occurrence? In all 3 cases, that was an easy yes, and this is because obviously the level of educational attainment had to come before the outcome of suicide. It only makes sense that way. Is there a dose-response relationship? This assumes that the more intense the exposure, the greater the risk of disease or outcome. Is this the case with 3 studies? Absolutely, and I will get into that in more detail later. So the dose response continued. What I'd like to point out here is essentially that there is a dose response for suicide associated with education, If you take a look at secondary school here, it has a p-value that is not statistically significant. However, when we get to those who only had a high school education and less, we do get statistically significant p-values. Now for study 2, this was the emergency department data study. We see that the p-value once again goes from being non-significant for the high school graduate status in this case to when the individual had less than a high school education, then the p-value was 0.002, which is highly significant. In the study itself, it says that individuals with a high school education or less, or those who are unemployed, were more likely to have a suicide outcome in the 12 months following the emergency department visit. For the third study, it looked at both males and females independently, and of course I have this all here for you to read on your own, but the main purpose of this was to say that there was obviously a population attributable risk of 22.6. This means that 22.6% of the suicide attempts here were attributed to the education level for males. This is the same thing that I've done. This was also taken from a table in my third study. And similarly to the males, I found that the population attributable risk for the females was 24.8% of the suicide attempts. Now, what about the strengths of these studies? Well, for study 1, Hamadan already had a high incidence rate of suicide, and this was a cross-sectional study. This means that it highlighted the most common and the most important risk factors for suicide. In study 2, we have emergency department data that had 2 chart reviews and 5 telephone follow-up assessments. In case you missed a person once, you were sure to get them again in future calls. And in study 3, the measurement bias was minimized due to using standardized diagnostic interviews. What were the weaknesses of these studies? Well, as I've indicated before, the first study was subject to measurement bias. The second study had some recall bias, and study 3 had a little bit of all. However, the benefits and strengths far outweigh the weaknesses of these studies. Findings and future potential research. Well, all 3 studies provided evidence for an association between lower educational levels and an increase in suicide mortality. It appears that I have enough information to support a causal relationship. To specify once more in regards to education, the 3 studies chosen here specifically look at a high school education or less. Now, while we have some answers right now, future research should continue to build an understanding of the factors associated to improve suicide screenings and interventions. Perhaps doing so could allow us to minimize suicide. Due to these findings, we now know the most common and important risk factors for suicide. This evidence could be used to influence research, policy, and treatment efforts. Here are my references. You can see I have a lot of Angus and Angus Deaton, who pioneered this area of mental health research. Thank you all for your time, and I can't wait to see everyone else's presentations. Thank you again for their time, and I look forward to seeing everyone else's research as well.